Good morning, good afternoon, good evening to everyone joining today's EPI-WIN webinar, and a special welcome to those of you who are from far-off places where it's really late or really early in the morning. Welcome once again to another EPI-WIN, and our second in our Mpox series. Today, our topic is going to be on treatment and medical care of patients with Mpox and their families. We have with us a very distinguished panel. Dr. Maria van Kerkhove will provide the opening remarks, followed by Dr. Espoir Malambaka of the Johns Hopkins School of Public Health. And he's also going to talk about the situation in DRC and South Kivu, followed by Professor Lucille Bloomberg, who's an infectious diseases consultant and medical microbiologist, and the former deputy director of the National Institute of Communicable Diseases in South Africa. Followed by that, we will then have a panel discussion moderated by my colleagues, Jamie Rylance and Tanya. In the panel, we'll have Dr. Andy Bulabula from Africa CDC, Dr. Steve Woolley of the Liverpool School of Tropical Medicine, Dr. Nerissa Woodley, a dermatologist currently involved in the South Africa outbreak, Dr. Steve Ye and Dr. Jean-Claude Mwansa, both ophthalmologists. So we get a range of experts on treatment. Today's EPI-WIN will also have a different structure, in the sense that instead of leaving the questions and answers till the end, we will have it after each speaker. So you will get your chance to ask questions to that speaker just after their panel. And the usual housekeeping before I hand over to Maria: this is being recorded. We'd love to hear from you, so please, as usual, introduce yourself in the chat and tell us where you're from and what you do. But for questions, please put your questions in the Q&A box, because we'd really, we miss it sometimes when it's in the chat. With the Q&A box, we can respond to you better. Without any further ado, over to Maria van Kerkhove, Director for Epidemic and Pandemic Prevention Preparedness at WHE here. Over to you, Maria.
Thank you so much, Supriya, and welcome everybody to this EPI-WIN seminar. I appreciate the EPI-WIN team and all of the team and the help from ECHO to pull this off. We're very grateful to have an opportunity to talk to you today about this really important topic. Just by a bit of background, I'm sure those of you who have registered for this are aware of the Mpox outbreak that is happening, or outbreaks, I should say, that are happening across the continent of Africa, primarily in the Democratic Republic of the Congo, but also in neighboring countries with this new clade called Clade 1b. But of course, Mpox has been around for many, many years. And we've seen other viruses of Mpox, Clade 1a, Clade 2, that have been in circulation and identified in many countries around the world. We at WHO are working with many partners around the world, with all of our member states, with researchers, with public health professionals, with dedicated people like you. I know many of you register for these EPI-WIN seminars to help prevent these type of infectious disease outbreaks. A few weeks ago, WHO issued a global strategic preparedness and response plan. This is the response plan that we are working with all member states to implement, and not just WHO's plan, but all of our plan, focusing on stopping outbreaks of Mpox transmission, with 3 objectives: to rapidly detect and control outbreaks, to advance Mpox research and access to countermeasures, and to minimize animal-to-human transmission. What we are seeing right now is largely human-to-human transmission through close, intimate contact. This is physical contact. And in some situations, we see this in sexual networks. We see this being transmitted through sex, but we also see close contacts among family members as well. And it's complicated. And so there are many teams that are working on the ground to help us understand better the epidemiology, better understand the transmission dynamics, because this will help us with the response. The response for Mpox is comprehensive. You may hear a lot about vaccines, but this is not a vaccines response. This is the response that is driven by strong surveillance, strong field investigations, precise risk communication, messaging, and engagement of communities working with local partners to prevent infections, prevent transmission, to ensure strong clinical care and home-based care, which you will hear about today, to ensure that those diagnostics are used to help people understand if they have Mpox or not. And then, of course, where we can, in addition to using public health and social measures, but also using vaccines in a targeted way based on the epidemiology, based on where the virus is actively circulating. So the purpose of this webinar is to give practical guidance on treatment of mild and severe patients, building on WHO interim guidance that was developed in 2022, guidelines, not guidance, that was developed in 2022. And our goal here is to share practical experiences from the field in the Democratic Republic of the Congo, in Ethiopia, and South Africa, in an effort to maximize effectiveness for response efforts, ensuring that treatment is timely, evidence-based, and well coordinated within and between communities. I'm very, very grateful for all of the presenters and the panelists today, joining us from the DRC, from South Africa, from Africa CDC, from the Liverpool School of Tropical Medicine, and from the US, for giving your time, for giving your expertise to contribute to this seminar and this discussion today. It's really, really crucial that we continue to share prevention measures and what you can do at home to care for patients who have Mpox, to share insights into diagnostic and management, especially in low and middle income countries, and what we can do to reduce complications, including for the skin and for the eyes. So I'll pass it back to you, Supriya, with deep gratitude to Jamie and his team and Janet Diaz here, who work directly with me, but to all of you who are willing to share your time and expertise with this large group of participants. Back to you, Supriya.
Thank you very much, Maria. I'd like to now invite Dr. Espoir Malembaka to talk about the treatment of Mpox. But before I do that, another announcement that this webinar does have French interpretation. So if you go to your box at the bottom of your screen that has a globe and go there and go to the French box, you will get French interpretation as well. And now over to Dr. Espoir.
Yeah, thank you. Can you see my slides? Yeah, thank you very much. It's a great honor for me to talk about the Mpox management in Uvira, in the Eastern Democratic Republic of Congo. So the DRC is a continent-side country. So what I'm going to say here may not reflect the situation in all the region or the provinces of the DRC that are now affected by the Mpox outbreak. So just I'm talking from Uvira, which is a city in Eastern Democratic Republic of Congo, sharing borders with Rwanda and with Burundi, sorry. And we know that Burundi also right now is also struggling with an increasing incidence of Mpox. So the first Mpox cases were officially documented in this city of Uvira on the 2nd of May this year. And since that period, we have recorded over 800 cases of suspected Mpox. And on June 8, 2024, thanks to support from MSF, an Mpox treatment center, as you can see the photos here, has been set up in Uvira. And we have now 2 tents and where we are treating Mpox, suspected cases of Mpox. What we are seeing in Uvira is that slightly we are having more women than men in the treatment center, but the difference does not look very significant. And we are seeing also, as this has been reported, an increasing incidence of suspected cases in young children. Actually, when you look at the age distribution of some of the cases that we have treated at the Mpox treatment centers in Uvira, you see that we have more than 50% of patients are children below 15 years of age. And these are like children who who are not yet sexually active. That means maybe non-sexual household contact is probably one of the dominant route of transmission of Mpox right now in many help zones of the DRC. And we are also seeing many cases of young babies who are breastfeeding, but whose mother don't present with Mpox symptoms. So we saw a sort of a clinical discordance between mothers and their babies for the explanation factors for this presentation are not yet clear to us. We are also seeing in Uvira an important proportion of people with anal and genital lesions. We also see that we have patients who are coming from very poor family with like the average household size of patients is 8 people. And we see that also many people live in households using toilets shared by multiple households. I will get back again to this wash situation in Uvira, because we believe that this is also one of the factors that might be driving the transmission, but that is not receiving the necessary attention. I think the diagnostic challenge has been discussed, and in Uvira, for instance, less than 20% of suspected cases have been tested. Right now, we don't have any Mpox confirmation capacity on site. We are sending samples to a reference laboratory, which is far away from Uvira, and we have had challenges in sample transportation. We have had episodes of like sometimes samples have been lost during the transit to the reference laboratory. We are having several weeks of delay in feedback from the reference lab. So most of the patients are being discharged without even knowing whether they are positive or negative cases. And in addition to Mpox confirmation capacity, we have very limited capacity for diagnostic and monitoring of comorbidities. We have HIV patients, but we cannot, for instance, measure the viral load. We cannot count the CD4. So all these challenges are not allowing us to provide the best care for these patients. So when we talk about Mpox diagnosis, yeah, confirmation of Mpox is critical, but it may not be sufficient. We also need to have a look at all these other comorbidities. WHO recommends the home isolation for like less severe cases, for mild cases. But the situation in Uvira is such that we cannot isolate properly cases at home. I said we have like an average household size of, the median household size of in household of patients is 8 people. We have like a ratio number of household size and bedroom in household of 4. So we have on average, I would say 4 people per household in Uvira. So with this condition, this is just an image of one household, which is in addition inundated, a single room structure where we have all the family members. When we receive cases from such families, we have challenges to really isolate them, even if they are just mild cases. We also have the other challenge. Sometimes it's hard to decide whether you want to isolate these patients in the Mpox treatment center, because we are going to have an overcrowded facility and people have to eat, we have to also look after them. And sometimes these are untested patients, keeping them in a place where we have so many confirmed cases may also be problematic. We also have challenges related to nutritional management of patients. A recent report from the Demographic and Health Survey in DRC suggests that 45% of children under 5 in this country have severe acute malnutrition. And before even the Mpox outbreak, we were having challenges managing severe acute malnutrition in children. Now we have Mpox, and I think the combination of both severe acute malnutrition and Mpox is probably going to be fatal in this part of the world. We have issues about the use of antibiotics. We have, I think we also need to invest in training of healthcare workers. We are also having situations where patients are claiming, they want to have IV treatment, even if they only present with minor symptoms. I think for some of the patients, not receiving IV treatment is synonymous of not being treated. And like healthcare workers are sometimes struggling to get them understand like the rationale of providing antibiotics. On the other hand, we don't have capacity in this hospital to monitor the antimicrobial susceptibility so we can provide the best treatment to the patient. Pain management is also one of the challenges. We only have access to the step 2 analgesics in Uvira. We have had patients like this one who have even needed like anesthetic treatment just to allow the healthcare workers to clean the wounds. And yeah, it has been, I remember my colleague, Dr. Musola, just bought from his own pocket, like the propofol, and has managed to get the anesthesis from the hospital to get on board and to help manage the patient while we are doing we are cleaning the wounds. So we need to really also involve other departments of the hospital in the management of the Mpox cases. We cannot ignore the general context of the Uvira situation. We have recently, we have had inundations because of the rise of the level of the Lake Tanganyika. So many families have lost their houses. We have a crisis of like access to clean water. So Mpox came to develop on, in a ground where we are having every year 1 to 2 outbreaks of cholera. I think with such conditions, it's really hard to manage, like to stop transmission of Mpox. When we are thinking about the Mpox response, we should not ignore the pre-existing wash conditions that may be conducive to the transmission of the virus. And we have had even some health facilities that have been struggling just to get running water. How do you conduct IPC in such conditions? It's really a huge challenge. So in short, I'll end by saying that there are some challenges that are specific to Mpox itself, but in Uvira and in many parts of the DRC, we have other challenges that have been there even before the Mpox outbreak. So we cannot really isolate the Mpox challenges from other health system challenges. And every effort we have to do, we need to account for all other these factors that are not directly related to Mpox. And when we are thinking about diagnostic, we really need to have confirmation capacity, but that may not be sufficient because we also need to identify and to monitor the comorbidities patients may present with. And I think we need to have this person-centered approach to how we organize healthcare services in Mpox treatment center. Thank you very much for your attention.
Thank you very much, Dr. Espor, for that overview. We will now go straight on to the questions and answers. As Maria mentioned, this webinar is possible due to my colleagues from Safe and Scalable Care, Dr. Jamie Rylands and Dr. Tanya. So I would like to request Dr. Tanya to moderate the Q&A with a few questions here from the Q&A box. And I'd like to request all participants to put your questions in the Q&A box. There is a question about how the disease has increased in children. For example, would anyone like to answer that? Dr. Espor?
Maybe I can start. Yeah. Initially, when the outbreak started in South Kivu province in Eastern DRC, we had a high proportion of patients who were like adults or people with history of sexual contact. But now we are seeing in many health zones, like the mode of transmission of the virus is changing, and we are seeing more and more cases in young age groups, children who are not sexually active. And you know, in this area where we have like overcrowded households, I think skin to skin contact, non-sexual contact is probably, and overcrowding are playing a role in the transmission of Mpox to young children. It's also not clear whether like older people in older age groups have some sort of prior immunity that it's not yet clear. So maybe children are too naive and the history of past exposure to the virus. That may also be an explanation.
Thank you, Dr. Espoir. Over to Tanya, maybe you'd like to put some questions to Dr. Espoir as well.
Dr. Espoir, I wanted to come back. There's a few questions around the prevention of Mpox. And of course, you raised the important concerns around access to WASH and IPC. So can I ask, please, what are some basic IPC and WASH measures that help to prevent the spread of Mpox between family members? Over.
Yeah, thank you very much for that question. I think hand washing with soap, for instance, has been shown to be effective in preventing many diseases. And I feel like in DRC, particularly in Uvira, in situation where people don't even have drinking water, let alone like water for hand washing, I feel like this is one of the factors that may contribute to the rapid spread of the disease in this place. And we see we presented some data on the ratio number of people per bedroom in this area. We have on average 4 people per bedrooms. So it means people live in overcrowded houses. So that is something we can struggle with. How do you recommend some sort of distance in household where you have a family of 10 people who live in maybe in a 2-bedroom structure? How do you minimize the skin to skin contact in such an environment? And like some of the WHO recommendations are really hard to implement in such situations. And like things like home isolation of patients with mild symptoms. We live in a context where like 90% of adults they work in the informal sector. So they have to do some small business on the street or in this open market to feed their family. So if they present with symptoms, how do you ask them to isolate until they are no longer infectious? That is just not possible. And that recommendation in settings like Uvira is not fit for purpose. I think we need to rethink some of these recommendations and adapt them to the context of low and poor settings like Uvira.
Thank you for that. I completely agree with you that we do need to be realistic and adapt the global guidance that WHO publishes. Related to that, there's been a question, Dr. Espoir, about the transmission of the disease. How is it transmitted between family members? What are the various routes of transmission that you are seeing in your context? Over.
Yeah, in my context, I think we still have a lot to learn about Mpox. We have right now in the city Mpox here cases of young babies who have Mpox, but their mothers, these babies are breastfeeding, but their mothers don't present any symptom of Mpox. Yet we have a very close contact between babies and their mothers. So it's not yet clear to us why we are having this sort of clinical discordance between sometimes babies and their mothers. But we are also receiving so many cases of like multiple cases within the same household, especially among young children. So we believe that, you know, maybe skin to skin contact. I don't know whether we have also transmission through a droplet. I don't know. All these routes are possible, and we are conducting investigation right now to try to understand the contribution of each mode of transmission to the current burden of Mpox in Uvira and other settings of Eastern DRC.
Okay, great. And one last question, perhaps. Thank you. What would you advise the minimum package for home care to include? What can you do? What's realistic on the ground there at the moment? Over.
What is realistic or what is accessible quickly? I think we need to promote hygiene practices like hands washing, for instance, with soap, and that is something we can do. That is something that can be achievable. But on the other hand, we have like challenges in access to just safe water in this country, and access to safe water is a multi-dimensional problem because we have the water supply agencies, we have the electricity agencies, because these water supply pumps and facilities, they work with electricity. That is a more complex problem, and I think it's beyond just the dimension of the health sector dimension. But I think hand washing can be promoted quickly and at a reasonable cost in these areas.
Thank you very much. I think we have to say goodbye to you, Dr. Espo, for now. Thank you very much for your presentation. Absolutely fantastic. And looking forward to your contributions and questions further on in the session here. I'd like to welcome Professor Lucille from South Africa. Over.
Thanks very much, Tanya. Thank you for the invitation. Can I have my first slide, please? I think you should have them. There we go. So a very different outbreak in South Africa compared to what we've heard, very different epidemiology and different in terms of resources. This would be a middle income country. So I'm going to look at some of the areas, stigma, sensitivities around the risk group, and then some of our challenges in terms of diagnosis and management. Can I have the next slide, please? And this is just a high-level view given the time constraints. So from May 24 to date, we've had 25 PCR positive Mpox cases. We know that there are probably a number out there who are not coming for diagnosis, given the sensitivities and stigma associated with Mpox and the risk group. And what we're seeing is probably the one end of the spectrum with mostly more severe diseases. All have been male, most where we get a history of have identified as men having sex with men, and all have been HIV positive. Presentations have been very similar to what has been seen in other countries where there have been Clade 2B outbreaks, and all our isolates to date are Clade 2B, part of the global outbreak, fever, lymphadenopathy, and a spectrum of disease, ranging from quite mild, as you see on the bottom right, to very extensive disease. And the extensive disease, severe disease, is absolutely related to a level of immunity suppression, undiagnosed HIV, or untreated or poorly treated HIV. So I think there's a very key message there that we have to link Mpox diagnosis and management and messaging and include them in the HIV programs. At the start of the outbreak, I think there was poor recognition of cases. We did have 3 deaths. It sounds a lot out of 25. We don't know what the true denominator is. One patient had an HIV-associated lobar pneumonia, had very extensive lesions, and could not gain access to critical care support. There's a lot of competition for limited beds. The other two were late presentation, and one of them, in fact, was a misdiagnosis by someone who was quite experienced in infectious diseases, but because it was the start of the outbreak, did not think about Mpox and misdiagnosed it as a deep fungal infection. We do have access to a very small supply of tecovirimat supplied on compassionate grounds by WHO, and we have used the tecovirimat according to the WHO guidelines, and to date in 5 cases. Next one. The biggest problem have been the diagnostic challenges. We do have good laboratory support, both in the private sector and at the National Institute in the reference lab, using PCR, and generally within 24 hours, we can supply a diagnosis to either confirm or exclude Mpox. The big problem is the very broad differential diagnosis of the clinical presentation. And when you have an outbreak, people suddenly are afraid to miss Mpox. Sometimes they forget their clinical experience. And so we've had a very large number of chickenpox cases presenting, and sometimes it's not easy to differentiate. And then a whole host of diseases that have presented, which outside of this outbreak would normally be managed within the setting, the epidemiology, children with hand, foot, and mouth, that would not have come forward as a possible Mpox case. I think what is important in our setting is to look at the epidemiology. What is the risk group? It's not a disease that's gone outside of that risk group now. I think clinical skills do vary. People are afraid of missing the diagnosis. And the other issue is that some patients have co-infections, especially other STIs and opportunistic infections in the same patient. I think what is important is overdiagnosis leads to poor use of resources. Patients are stigmatized until you can get a negative diagnosis. And that it's also important to remember that many of these alternative diagnoses, especially say severe chickenpox in an adult, also do require treatment. So it's not just about Mpox, it's about managing them properly. Next one. So some key messages about management. I think a lot has been said about a package of care. I think nutritional support is perhaps less of an issue here compared to the DRC. Treatment of secondary infections, I think, remains important, and there aren't very good guidelines. I think skin care is the question I'm most often asked about. What would be appropriate? And I think, we need some guidance there. And home isolation or hospital isolation is absolutely possible in our setting. I think the key message I really want to get across is to link diagnosis, treatment, and prevention in our setting to HIV programs. We know from previous epidemics that many of the important public health programs are neglected. In COVID, TB, HIV were some of those. But for Mpox, it's absolutely critical to ensure that HIV is diagnosed early and treated properly, given the link with the complicated Mpox. An important message to manage the opportunistic infections and concomitant STIs. Syphilis may be hiding there. And then I think not a lot of information about or good guidance on when to start ARVs. There is, I think, not a lot of experience or problems with iris to date. We had one patient, as you see below, who was treated with 2 weeks of tecovirimat. I think he took his own form of ARVs when he wanted. He discharged himself after 2 weeks, came back with new lesions, and then it was the question, is this an iris or is this just the patient requiring longer tecovirimat? And it's obviously the latter. If it was iris, the current lesions would get worse. If there are new lesions, it's probably an ongoing infection requiring a much longer course of tecovirimat. So there are these treatment issues. The second major issue are psychosocial considerations. The stigma, the sensitivities associated with particularly HIV diagnosis in an MSM setting in Africa. This has created a lot of stress in our patients. and needs to be managed very sensitively. Contact tracing is very difficult. Patients don't know who they've had contact with, or they're unwilling to share it. And I think sometimes one has to leave them to inform their contacts. But when you're looking at a post-exposure vaccine program, which we haven't yet reached, that becomes a bit of a challenge. The last challenge is the sequelae. There's not lots we know about, but I think the depigmentation is something that we need to recognize and perhaps put some effort into management. So that's just a high-level look at the outbreak here and some of the key issues. Thank you very much. I'm done.
Thank you very much, Dr. Lucille. Now, we would like to ask the participants to put questions for you. That was very interesting in two different scenarios, as you mentioned.
Yeah.
Over to Tanya, requesting Tanya to please moderate the questions.
Thanks, Lucille. Wonderful presentation. A few questions have come in the Q&A box around why so much stigma, and is there misinformation in the communities, and why individuals are fearful or to come forward for assessment? Is it because they are scared? So a few questions around that. And then a question to you, please, around the ideal skincare package. And I know we have others talking to this point a little bit later, but your experience in South Africa, just an overview on the skincare package would be marvelous. Thank you. Over.
Yeah, I'll take the second question first. So I think the recommendation is to keep the skin clean and dry, and to treat any secondary infections of the skin appropriately. I think it needs a little more guidance in a package of care for low and middle income countries. And I think that is not there. I've been asked all sorts of questions about, should you put them in sodium bicarb baths and treat them like burns? I think, it's not all clear, but it's to keep them dry, keep them clean, and use a local antibiotic, not in excess, if there are secondary infections. But you can see the extent of them. And many of the lesions are in quite sensitive areas where they are likely to get secondary infected, perianal, for example, around the mouth. So I think it'd be good to have other people's experiences from other countries and other outbreaks. So I think, I don't need to tell this audience about stigma associated with HIV, but I think we need to remind people about the stigma associated with MSM communities. We need to use our special groups to reach these communities, to be involved in, bringing patients to care a little earlier. And I think we all are aware of the stigma around MSM in Africa. In some countries, it's a punishable offense. And to many of this community, they've not come out to family and friends, and I think they're afraid. So, yeah, I think we could have a whole hour on, psychosocial issues. But I know Narissa's on the call later, and we've had a number of patients who've wanted to commit suicide, to leave. It's something that's quite neglected, but is a particular issue in this outbreak, given its associations in the setting.
Thanks, Lucille. And yeah, I mean, it's a very complicated disease. And someone else also raised the question around what pain relief are you using? Because some of your slide presentation clearly showed patients in obvious distress with extensive lesions. So what pain relief do you use, and what in South Africa for nutrition, the nutrition support, what are you using to support patients that are either malnourished or cannot eat? Simply, over.
I don't think we have the same challenges as they do in the DRC, Burundi, where food security is a major issue. and poor nutrition in children is clearly a key issue. So, I think most have managed to eat, to have fluids, and it's the same guidelines as other people have used for pain. We just need to pay a bit more attention to pain management generally in patients. We use, from mild analgesics, you have access to virtually the whole spectrum that are recommended in the guidelines. So I think it's about being aware of patients and pain in this setting. I think that's much more important. I think the drugs and the support are there. It's just bringing it into your package of care.
Completely agree. And have you seen any patients cured, recovered from Mpox, and then coming back again with reinfected at all?
So they're not reinfected, and they're not iris.
Okay.
So the one patient I showed had some healed lesions and had new lesions. And that was because he stopped his treatment, his tecovirimat, after 2 weeks, decided he wanted to go home, was on and off his antiretrovirals. So we think that was an ongoing infection. And the recommendations are to treat those sort of patients with anything up to 4 to 6 weeks of tecovirimat. So he wasn't a reinfection, he was an ongoing infection requiring longer treatment. So we've only had one of those patients. The rest have actually just got better, either with tecovirimat or without.
Okay, super. And
the ones who died, I think, were too late.
okay, and it's not clear that you've seen too many children, but there is a question around, in your opinion, do children appear to sort of recover faster than adults? I mean, I guess it depends on the extent of the clinical presentation, but what's your opinion, at least?
We've had no children. We have a very clear risk group. I think that question is best asked to the group in the DRC, who've had the most experience with children, obviously in a difficult setting.
Okay, thank you.
Tanya, you're muted.
Sorry, Dr. Espor, just to answer the question for those people that are interested on the children issue, do you see that children recover more quickly than adults in this particular outbreak, please?
From my observation, I think that maybe the duration of hospitalization is longer for children, especially for young children compared to adults, because children, they are presenting with more severe forms of Mpox than adults, and they tend to stay longer in the hospital, and they tend also to need intensive care more than adults. But we are actually right now looking at the data, and we will have something published soon on that. Maybe if I can take advantage of this moment, just one thing I would really love to highlight, some of the household risk factors for Mpox are maybe very hard to address in the short term because they are just indicative of the socio-economic situation people are living in. But we now have vaccines that can help to mitigate some of these risks, especially in close contact. I think probably vaccines may be a tool. And we are currently running a survey, a trial in Eastern DRC to assess how the MVA-BN vaccine can be effective in post-exposure prophylaxis when given to contact. I think we may not change the poverty situation of people, but we may help them, protect them through vaccines. Yeah, thank you.
Thank you, Espor. Fantastic. And thank you, Lucille, for a wonderful presentation and discussion. Thank you for answering the questions, both of you. I'm going to hand back over to Supriya. Over. Thank you.
Thank you very much, Tanya. And now we get to the really exciting panel discussion, which I request Jamie Rylance, Dr. Jamie Rylance, Technical Officer, to moderate, along with Tanya Kelly, who you're familiar with now. And we have as panelists, Dr. Andy Bulabula, Dr. Steve Woolley, Dr. Nerissa Woodley, and Dr. Steve Ye, and Dr. Jean-Claude Mwanza. Over to you, Jamie and Tanya. And I know you have some exciting questions for this group of panelists. Over to you.
Thanks. Exciting questions, but more exciting answers, I hope. So I'm going to start. Espoir showed a very rich picture of the environment in which he's working, and clearly this varies a little bit. But I'm going to ask Andy Bulabula to talk first about prevention measures in the home. That's come a lot in the chat in terms of what practical measures can we do to stop Mpox transmission in the home, and how does that vary according to different environments. Over to you, Andy.
Yeah, thank you very much for the question. I will share a very brief slide containing some of these IPC considerations. Although this may be focusing on healthcare workers and patients, but this can be also applicable to home-based care. Well, the presentation by Espoir is very loud speaking because of the poverty-related conditions there, where people are living in such overcrowding and overcrowded environments. The contact is very likely to happen. Skin-to-skin contact is very likely to happen. And the close contact, like being less than 2 meters away, is also a risk factor for droplet transmission. It's making it very difficult to implement IPC. But nevertheless, we should consider a few elements. It's like we can still use one part of this house as the isolation area, and make sure we have at least 1 meter apart from those who are sick and from the family members who are taking care of them, and ensure that we have a well-ventilated home. So they can still achieve that using natural ventilation. This means they open doors and windows just to allow proper ventilation. But also hand washing or hand hygiene. Espoir made it very clear. Hand hygiene still the cornerstone of IPC in many situations. We can still use that in Mpox in an area where poverty is really paramount. But also the environmental cleaning. How do we deal with the environment surfaces, environmental surfaces cleaning? How do we disinfect the linen, and how is the sharing happening? So we should make sure the handling of patient materials is really strict, and we don't share the linen with the sick people. So the patients can keep their own, and when dealing with it, we need to be extra careful in terms of not really shaking the linens, but really putting it in an area where we can properly clean, wash, and disinfect it. The good news is that the Mpox virus is very fragile, and usual disinfectants can really achieve the right disinfection of the surfaces and the materials. So the patient's family members can protect themselves in a way that they don't allow very skin-to-skin contact and or mucous membranes exposed to potential droplets. So they may use medical masks or medical mask, because in home-based care, we are not expecting to have aerosol generating procedures, and that's by itself will reduce the level of requirement in terms of N95 or other respirators. So in a nutshell, we should advise and educate family members to simple IPC measures like contact precautions, washing their hands, ventilating the house using the natural ventilation mechanisms, and of course dealing strictly with the linen. Don't share in a house where there is a sick person with Mpox. If there is any other question, I'll be happy to comment more. But in a nutshell, this is what I want to share. Thank you.
Thanks very much, Andy. Perhaps just a follow-on question. There's a few questions in the chat about transmission outside the home, and I think in public places and public transport and other things have been mentioned in the chat. Do you want to comment on that and how protection measures work to prevent transmission outside of the home?
Yeah, thank you very much for that question. In fact, it is very important to remember that we don't need to come into contact with the lesions of the person who is sick, and we should be able to clean our hands as often as possible, clean and disinfect the surfaces around us. And of course, when we have this rash or any symptoms and signs, we should isolate immediately and seek medical care, medical attention. So first of all, the contact precautions are important. Ventilation of crowded places should be an element to consider here. And of course, cleaning and disinfecting the surfaces is another one. And just respiratory and cough etiquette here is respiratory hygiene and cough etiquettes are part of the package of IPC measures that we need to use while in public. And of course, it is also applicable here that physical distancing, whenever that is possible, we should observe between 2 meters, if possible, from the sick person, especially if these ones are presenting with respiratory symptoms. Over to you.
Thanks. So you're talking about general measures for infection prevention and control, and then specific measures where the Mpox is a person with Mpox has been identified in terms of isolation at home or in the environment they find themselves. Thank you. I'm going to move to Dr. Nerissa Moodley, please. A huge number of dermatological questions, and I think we'll come on to severe disease, but there's a lot of interest in the chat about understanding what a typical Mpox rash looks like, how it presents, and the degree to which you can expect typical or atypical kind of presentations. I wonder whether you want to start there, Nerissa. Over to you.
Hi, good afternoon, everyone. I'm just going to go through some of the cases that I've seen with the Mpox infection, and I've seen these patients at my hospital just to give a brief idea.
Nerissa, you're a bit frozen, but we can see your slide. If you hear us, go ahead. I think we may have to come back to Nerissa. I'm going to move.
Yeah, back again.
Go on. Go, Nerissa. Sorry, I wasn't patient enough. Carry on.
No problem. Are you able to see my slides now?
We can. Go ahead.
Okay. I think you just need to come through to me again. I think this is not working, and I will just try and reshare this.
Okay.
There we go. Is that better? Yes.
I can now see your second slide. Go ahead.
Are you able to see that now?
Yes, we can see Mr. LF.
Okay, sure. So Mr. LF was a 39-year-old male, also RBD positive, diagnosed in 2023, and he had a comorbid disease of diabetes mellitus. He had a 2-week history of a generalized rash that was very painful. He also had urinary retention with a mild headache, a sore throat, with no other history outside of KZN. So on examination, he was very fully conscious, alert, and he had these extensive generalized vesicles and pustules on his scalp and face. Some of them were very firm, well demarcated with central umbilicated pustules. Some of them were oozing, and some were also secondary infected. Systemic examination was normal. However, he was complicated by a viral colitis, hematochezia, perianal abscess, and conjunctivitis. He was also hepatitis B positive. He did complete 14 days of tecovirimat. So again, this was the patient on day 0 of presentation and after 14 days of medication. And then extensive lesions you can see on the face and after 14 days of treatment. Again, you have this umbilicated pustules on the trunk and that have crusted on day 14. However, and you can also see that he has extensive palmar plantar lesions as well. This patient was prematurely discharged. He did sign RHT. However, he was readmitted due to gastroenteritis and dehydration. And then he had these new annular well-demarcated plaques, and that was present on his chest and on his palms, and they range from about 2 to 3 centimeters. He already also had extensive oral lesions, and we have done repeated pus swabs for him, and he did confirm that he was an Mpox positive. He did complete a total of 6 weeks of tecovirimat, and upon discharge, what was interesting is that he was noted to have erythematous plaques on his tongue, which was later confirmed to be Kaposi sarcoma. So this is the patient on day 20, and he had new lesions. And again, after 42 days of treatment, most of the lesions had healed with post-inflammatory hyperpigmentation. And again, extensive lesions on the face, and this is how the patient had healed. You can also see the extensive oral lesions that he presented with. And upon discharge, you can note that he had extensive erythematous plaques in his tongue that confirmed Kaposi sarcoma. So the next patient was that of a 30-year-old male, also RVD positive with a CD4 count of 575. And he had a 4-day history of these pustules in his groin area. He had no other systemic symptoms, and he was a well patient. He was discharged, and he did not start on any treatment. You can see that he has extensive lesions in the groin area with scrotal swelling. And then this was on 7 days. He did not receive any treatment, but he did receive some antibiotics for secondary infection. And again, scrotal swelling with extensive lesions on the groin area. And that's how it healed on day 7. The next patient was that as a 23-year-old male, and he was also RVD positive, and he had an 8-day history of these pustules on his hand with no other associated symptoms. Again, he was very well, and he had about 10 scattered pustules. They were healing, and they were scattered throughout his body. He was discharged home. The next patient was that of a 27-year-old male, HIV positive, and he had a 6-day history. And you can appreciate the different types of lesions that I'm showing you, from extensive disease to very mild disease. Again, very well, and you can note that the pustules associated on the groin area with no other systemic symptoms. And the final patient that I had seen was a 21-year-old male, RVD positive, with a 5-day history of these pustules, extremely well with no other associated symptoms, and isolated at home. Okay, so just a summary of the cases that I've seen. Most of them were male, most of them were between the ages of 20 to 40 years of age. All of them were RVD positive. You can see the CD4 counts range from the very severe disease of 13 with a very high viral load. And then it was the other patients that had very high CD4 counts and lower than detectable viral loads with very mild disease. And just one patient, was the first patient, was not on antiretrovirals, and he did have systemic and other complications. So just to note the clinical stages of your Mpox lesions, followed by your incubation stage, your prodrome, and then your eruptive stage. And then your lesions, which are very firm, well demarcated and umbilicated, that range from about 3 to 15 millimeters. Again, you have your macules, your papules, your vesicles, pustules, and then eventually scarring. And here's just some of the lesions that we've seen: very early vesicles to late vesicles, umbilicated pustules with central crusting, and again, partially removed scabs with very severe crusting of the lesions. And you can see how wide the disease ranges from. And then eventually they do heal with post-inflammatory hyperpigmentation. Again, you may have other clinical features like penile edema, paraphimosis, rectal pain and pain on defecation, oral involvement, ocular involvement, and other complications as well. So in South Africa, we've seen penile edema, we've seen conjunctivitis of the eyes, oral extensive lesions, and they may range from very mild disease with very isolated pustules, again, very mild disease, and then to extremely extensive disease with very annular, large plaques and pustules. This was another patient that had very severe disease, and this is just to illustrate how he presented with pustules, then healing with scabbing, and eventually post-inflammatory hypopigmentation. Again, another very severe disease that we've seen in this patient. This patient unfortunately did demise. And then again, just to remember your differential diagnosis, that includes your bacterial infections like bacillary angiomatosis, secondary infections and ecthyma, viral infections like hand, foot, and mouth disease, molluscum contagiosum, varicella as well, and herpes simplex and zoster, and your deep fungal infections like your histoplasmosis, cryptococcosis, emergomyces, sporotrichosis, and Telleromyces monophyly. Thank you.
Thanks, Narissa. That's really clear in terms of showing the breadth of typical or atypical presentations and how the lesions can evolve over time and affect different areas of the body. Clearly, you see quite severe disease in the cases that you've described have all been context of HIV and immunosuppression. I wonder whether you want to comment on the severity of disease throughout multiple of these different outbreaks and whether how typical you think these rashes are for the generalized outbreak, and to what degree HIV and other things affect the severity, because we certainly know it's a risk factor for severe disease.
Okay, so Prof. Limburg did mention that most of the patients that we've seen in South Africa actually do have HIV. So the patients that had very low CD4 counts present and were not on antiretrovirals had extremely severe disease. And you can see that by the extensive lesions, they had oral lesions and more than 100 lesions all over the body. Whereas patients that had good CD4 counts that were on antiretrovirals, they had very mild disease and very few pustules, and most of them healed with just post-inflammatory hyperpigmentation, and none of them did require medication with tecovirimat.
Thanks. And very briefly, because it comes up quite a lot, and I said I would ask the rate of superadded skin infection, the people that you need to treat with antibiotics. Do you have a handle, perhaps not in the population you're seeing in hospital with HIV, but perhaps across the epidemic more broadly? Do you have a handle on how frequent and how severe that is, and what your typical approach would be?
Okay, so the typical approach would be to first make a diagnosis, and that would be to do your PCR testings to test for the Mpox disease, and then just to think about other secondary infections that can occur. Remember your STIs that are very prevalent, other concomitant diseases as well, especially your deep fungal infections that we do see in South Africa can mimic the Mpox infections. And what I do suggest is that if they are secondary infected, to start them on a broad spectrum antibiotic, make sure you have an antiseptic wash just to prevent the infection as well. And then just a topical antiseptic as well, just to help with the secondary infected of the lesions.
Thank you very much. I think we may come back to you if we have time to describe home care and skincare at home, but we'll just move, while we're talking about severe disease, please, to Dr. Steve Woolley, who's going to, I think, just give us a little bit of an overview about other severe cases that have required hospitalization. Again, on the background of knowing that probably most of the cases in most of the people with Mpox in current outbreaks are not admitted to hospital and do not have severe disease. And we are picking up on this because a number of questions come about how to treat the more difficult end of the disease spectrum. Over to you, Steve.
Thanks, Jamie. We'll just wait for the slide deck to come up. But the experience that I'll be reporting is primarily from the UK, which I recognise after working overseas is extremely resource intense, and a lot of this information has been produced through our high consequence infectious disease network, but certainly sharing the experiences with other colleagues overseas as well. So I've helped Lucille and Larissa with their patients in South Africa. So my task is hopefully to give you just a bit of a flavour about severe disease and that spectrum. Next slide, please. So I won't talk about ophthalmic disease. There are a lot more experienced specialists on the call to talk about ophthalmic disease. But I think what's important is just to recognise some of the other diseases spectrum that you may see in Mpox, such as CNS disease. We'll talk about severe skin and soft tissue, which can lead to deeper collections, and also some of the issues that we saw in our cohort related to significant rectal pathology, especially in those that were immunosuppressed, not only from HIV, but for other reasons of immunosuppression. So next slide, please. So colleagues in Sheffield managed a case of encephalitis that was confirmed to be related to Mpox. The very potted history was a 35-year-old female, which was unusual in the 2022 outbreak because it was a very skewed towards men, particularly from the gay, bisexual, and men who have sex with men community. And she presented with vulval lesions and headaches. It was initially thought to be related to herpes simplex and was treated down that pathway, but very quickly in that admission was recognised to have Mpox and was subsequently PCR positive. However, about day 10 into the disease, she dropped her Glasgow coma score and had ongoing fevers. And had a lumbar puncture, which showed a leukocytosis of about 16 white cells, but normal CSF protein and glucose, which is a little unusual, but is being seen in a few other cases of Mpox CNS disease. And the CT values were pretty good and convincing of Mpox disease. And unfortunately, despite the addition of tecovirimat, the individual continued to progress and required a critical care admission. And you can see the MRI head, and also which shows deep white matter lesions, multifocal. But also the individual then developed transverse myelitis as well, which required extensive steroid therapy because the presumptive was that this was immune mediated. She was given a prolonged course of tecovirimat and made a good recovery overall. And I've attached the reference to the slide deck, which will be available, which gives you more detail about the case, but certainly led to a lot of significant challenges of managing a patient in critical care, which we have experience of in Liverpool as well. Next slide, please. So we give an example in CNS disease of encephalitis and myelitis, but we've also got this neuropsychiatric issues as well, which Lucille raised very starkly. And we saw a number of individuals that did have psychiatric symptoms, particularly severe depression, which was related to the stigma around Mpox, and had to be significantly managed because our patients were isolated in our high consequence infectious disease units, and again proved to be challenging even on the milder disease spectrum, but it's important to think about. So next slide, please. What we did see early on, so one of the first patients that we saw in 2018 in Liverpool, which is described by one of my colleagues, Hugh Adler, we saw an individual who had returned from Nigeria who had severe skin disease. He was HIV negative, but had a large number of lesions, and subsequently was found to be heterosexual transmission, sexual transmission. But he had very deep groin abscesses, which we presume to be secondary bacterial infection, but required surgical intervention to drain these lesions. And we did not have any evidence, despite broad antibiotics, of any positive secondary bacterial infection, and actually had very high CT value of virus within those lesions. Once we had managed to surgically drain these lesions, the patient reduced their fevers and reduced their symptoms. And this was all despite tecovirimat. We were one of the first groups to use tecovirimat on an Mpox patient. And again, despite that, the antiviral treatment required surgical intervention. So it's important to look out for if you are having individuals that are not resolving their fevers or other clinical signs or symptoms. Next slide, please. What was also described, again, by colleagues in London, but we also saw in the wider network, was certainly in the gay and bisexual and men who have sex with men risk factor group, who had receptive anal intercourse, had extensive proctalgia, which was very difficult to manage in terms of pain management, psychological management, but also clinically. And then we had a small cohort of individuals that had rectal perforation because of the hyperinflamed mucous membranes within the rectum. And it again required surgical management in a number of individuals to get clinical resolution for those individuals. Next slide, please. So what we have used subsequently from the 2022 outbreak is this management ladder, which was devised by Jake Dunning, who many of you will know on the call, which has been used extensively throughout the Mpox network when we had the outbreak. And regular analgesia is paracetamol, and again can be either oxycodone or tramadol, depending what you will have available. And for the severe end of the spectrum, Jake had very good success using oral ketamine to reduce the signs and symptoms that the patients had. They also used PRN oxycodone and also buccal fentanyl to help as a PRN top-up for the pain relief as well. What was also really important was laxatives and ensuring that we didn't constipate the patients with the opiates. And a bit further on in the outbreak, there was good use of naloxone, which is a naloxone containing oral solution, which can provide some help in managing opiate-associated constipation. We also had good evidence of using rectal mesalazine, which is also used in inflammatory bowel disease, to provide good relief for proctalgia, as well as the other analgesics. The other thing that we noticed, which was worked really well, particularly with our male patients that had penile lesions that had a degree of urethritis, was lignocaine gel, which again provided good relief to those individuals to be able to help them pass urine without going into retention, which we did see early on in the outbreaks. Next slide, please. And lastly, we did not see a huge number of individuals with HIV, but a global consortium managed by Mita et al. Managed to collate a retrospective cohort on the patients with HIV who were infected with Mpox in the 2022 outbreak. There was a small cohort that weren't on antiretrovirals, and then there were a question of around about 21 that may have developed an iris, but those were new diagnoses of HIV. Some were poorly concordant to HIV medication. But what was apparent was all those individuals had CD4 counts of less than 200. The Mpox symptoms was 21 days, but the median time from restarting ARVs to symptoms that could have been consistent with iris was 14 days. Some had good resolution with steroids, but unfortunately a half of that group passed away, but was thought that it was actually related to other opportunistic infections because those individuals were hospitalized and critically unwell with severe HIV. We also saw
I'm going to have to stop you just in case we don't give enough time for the last presenter. But thank you. I think that's shown the very severe end of the spectrum what challenges you face with both pain relief complications and co-management of HIV, which has come up in the chat. Thank you very much. In order that we just speak to what's an increasingly recognised and certainly worrying problem is ophthalmological or eye problems associated with Mpox, and this clearly has implications for the acute disease, but also any long-term complications and loss of eyesight is clearly something that worries people and patients in particular. And I wanted to just hand over to Steve just to give Steve Ye and Jean-Claude Mwanza to give an overview of this, what was known so far, and what the pragmatic treatment options might be, knowing that I'm always close to the wire and we need to finish at past. But over to you, Steve.
Absolutely. Thanks, Jamie, and we'll be brief. But really, I think Dr. Woolley and Dr. Moodley certainly highlighted the multidisciplinary nature and importance, and I appreciate everybody recognizing the ophthalmology implications. And so if we could just have the slides. I just wanted to first, I'm a uveitis and ocular inflammation and retina specialist, and I work a lot with infectious disease, and I'm pleased to be joined by Dr. Mwanza. And I was with Dr. Mwanza just about a week ago in DRC, evaluating some of the infrastructure, and he'll be speaking to the specific clinical implications. But what I wanted to, we can go to the next slide, please. What I just wanted to frame, just the broader conversation, is that the eye really represents a window to other emerging infectious diseases, and these emerging diseases do have their they seem to have their distinct ophthalmic manifestations. We've worked a lot in the Ebola space related to uveitis and ocular inflammation, but Mpox seems to have quite a bit of conjunctiva, sclera, and also corneal manifestations, but we also need to keep other emerging diseases, including HPAI, on the radar. And so at this point, I'll hand it over to Jean-Claude to talk a little bit about the clinical manifestations and what he's starting to see in DR Congo. JC? Next slide, please. I think, JC, you may be on mute.
Yeah, I was saying, thank you, Steve, for the introduction. So Mpox has a range of ocular implications, and among those that have been described in the literature include periocular lesions, blepharitis, which means the margin of the lid inflammation, conjunctivitis, and different type of keratitis. And in rare cases, we can observe uveitis, which means intraocular inflammation and hypopyon. Next slide, please. Yeah, corneal complications can present as superficial or stromal keratitis, and even as corneal ulceration. To the left side, to your left side, you'll see this is a case of epithelial keratitis that started in the periphery and progressing to the center of the cornea. And in the middle picture shows another case of peripheral keratitis. Excuse me. No. Previous slide, please. Yeah, corneal ulceration is a serious complication, and it can lead to other complications if it's not treated at all, or if it's the treatment is started very late. This is a case of corneal ulceration that was treated. So it's before and after treatment with tecovirimat, systemic tecovirimat. Steve?
Great, thanks. And so as JC mentioned, there's a range of ocular complications, mainly anterior segment. And one thing I did want to highlight is that this can be very, as it would appear, very painful. The patients will have eye redness, decreased vision, and often light sensitivity. And we'll go to the next slide. And what I wanted to highlight is that one also thing that we're also seeing in the literature and in consideration from an infection prevention and control perspective is that we are seeing positivity of Mpox DNA. There's a report out of UCSF, some of our colleagues from Proctor Foundation, that showed Mpox confirmed in the sclera and cornea. And there was another recent report out of Lancet Infectious Diseases that showed that there was persistent Mpox ocular involvement at up to 8 months with quite a long-term identification of PCR positivity. And so something that's important as we think about, let's go to the next slide, as we think about the management options. The reports thus far have reported, and these are very limited in terms of from a therapeutic perspective, but some success with tecovirimat and systemic antiviral treatment, and topical trifluridine is used. It's indicated for herpetic disease, but has also been used for corneal involvement. But some of the preventive measures, I think this was alluded to in terms of home care, that you really can't underestimate and overemphasize the importance of hand washing and hand hygiene. If somebody has single eye involvement, preventing contralateral eye involvement and avoidance of eye rubbing. I'm very guilty of that, certainly, but I think that it's important to, just as a reminder from a care perspective, and this is also important for the care providers who are in the field, eye care providers, just because of the proximity between the instrumentation and the equipment that ophthalmologists and eye care providers will use, just to have, again, control of the source control with the medical masking for the patients, as well as appropriate PPE. And we'll stop there, just so we'll have some time for any questions and discussion. Over.
That's great. Thank you both. Really appreciate your emphasis on some of the prevention measures that people can take at home. Knowing that healthcare workers, I think, have mentioned in the chat that it might be sometimes difficult to know who they should refer to if they have a referral pathway to an ophthalmologist, and what the signs and symptoms patients and their families and then healthcare providers should look for and worry about, because again, this is a minority of people, but it's an important minority.
Yeah, absolutely. I would just, the one comment that I would make is that again, it really is like the big picture that Dr. Moodley showed, all the characteristic skin lesions, and some of the times these lesions can be a bit distal to the presentation of the ocular manifestations as well. And one perhaps more concerning case was this one from San Francisco, where there were very minimal to no lesions, no skin lesions that were detected. But in the majority of circumstances that we've seen, these are the periocular and facial lesions that will have resultant ocular inflammation and symptoms and signs that are quite characteristic. But as you mentioned, there are some of these minority of cases that we need to be also just to have on our radar.
And so what would be the questions that you would ask as a healthcare worker to identify the patients that might be either at risk or developing eye problems that should seek further intervention?
I think in the active stage, when we think about ocular symptoms, we will think about things like pain, redness, light sensitivity. Sometimes patients will complain of an early foreign body sensation that should just also be on the radar. But I think in the same way, I sort of liken this to our understanding of Ebola virus disease, that sometimes patients didn't necessarily know what types of symptoms. Is this a normal phenomenon to have blurred vision after this condition, or is this something that's abnormal, that they know that it's important to reach out to a healthcare provider if they were to develop some of these early symptoms. We're still learning about the evolution, that some of these patients who are presented with an early mild eye redness or conjunctivitis can evolve over time. And so it's important, if they do have symptoms, that they seek healthcare provider advice, and certainly ophthalmology where available, which can be challenging.
Thanks very much.
Yeah.
I'm gonna before Supriya kills me for running over time, I'm going to say thank you very much to all the panelists. Really appreciate your time and expertise and highlighting some really important points. I have tried in the chat to point to some of the WHO resources, including the Mpox page, the Q&A, and the overarching global strategic preparedness and response plan that identifies the components of the Mpox response that Maria Vankakov spoke about at the top of the conversation, that defines how we address that then needs to be localized and implemented. Clearly a lot of challenges, and thanks to our panel for highlighting them. Back to Supriya.
Thanks, Jamie. Thank you very much for that session, and thanks to each and every one of the panelists. I was wondering how this session would go, but I don't think in the history of EPI-WIN we've got so many heart emojis. So thank you very much, and thanks very much to the participative audience as well. Jamie, are there any further questions you would like to place from the Q&A for the audience? We have 4 minutes.
Okay.
Or should we just wrap up? One more question, perhaps, if you would like.
It feels like we would be remiss if we didn't ask a further question. I think most of the conversation in the chat has been about how rashes develop and the time frame for rashes developing. And I wonder whether we should just go back to Narissa just to run us through what the typical rash looks like. I know you've shown the slides already. What we should be looking out for, just as a very high level summary, so that we have it in our minds when we see patients and when we are looking for patients with rashes.
Okay, so when a patient would present to you, they would obviously have some prodromal symptoms, flu-like symptoms itself, and they would have these very typical umbilicated pustular lesions, and they almost look like molluscum contagiosum. So they would have these lesions, they start around the anus regions, they can have them in the penis regions as well. And then you have these, the rash and almost pustules, they can lead to scarring and then eventually scabs as well. So very acute onset of molluscum type lesions that are very significant of the pox virus itself.
Great overview. And I think, Supriya, we should leave it there. Thank you very much.
Thank you very much. Thank you very much, first of all, to the greatly participative audience. We really appreciate your questions, your comments. I see we have almost 150 questions. So, the great interest and engagement there. Thank you to each and every one of the speakers and the panelists. I think, the quality just shows in the feedback that we're getting here. Thanks most of all, though, to Jamie and Tanya. This is all their work completely. So, and a lot of work has gone into this webinar. So thank you very much. I'd also like to thank our colleagues from Project ECHO, with whom we collaborate for the webinars. Thank you. They've been working in the background, sharing the slides, inviting everybody, making sure the logistics gets done. So a lot of work there. And also thank you to my colleague Sadrish, who's sitting in this room right next to me, and has been doing a lot of the work very quietly in the background. And of course, the interpreters who make this so much more accessible to everyone. Before we go, I'd like to share with you that next Thursday, we're back to Thursday again at 1 o'clock Geneva time, 1300 hours Geneva time. We will be having the third of our Mpox series. It will be on collaborative surveillance. The QR code is there. So please do join. And we look forward to seeing you next week and hearing from you. Thank you once again. Bye.